isn't stable, so if there's any interruption, please stop me, okay?
تمام.
Okay. So we start with common pediatric infectious disease. There's two parts. Part one is the heaviest one. It's about common viral infections. And part two about common clinical syndrome. I'm Lanud Jarbo. I'm pediatric ID consultant and assistant professor at Imam University. So prior to start, just I would like to share a motivational quote. Prior to COVID, I was questioning my career and my subspecialty as of most of the viral infection is prevented by the vaccine, and we are left only with the hospital-acquired infection. Till COVID hit and changed not only my career, changed the whole world. So every day we learn a new thing. So this is Eric Hoffer, he's an American philosopher. So he mentioned in times of a change, learners inherit Earth, while the learned find themselves beautifully equipped to deal with the world that no longer exists. So keep learning and enjoy learning. So for each viral, we will talk about incubation period, mode of transmission, and clinical manifestation and management, and if there is any preventive method. Just to keep it more interactive, I will share some hints and I give you some letters so you can make the viral or give me what is the viral. So let's say this is a 15-month-old boy, unvaccinated, presented with cough, coryza, conjunctivitis, and then he developed maculopapular rash in a descending order. So what is the virus? Any guess?
ممكن measles.
Exactly, measles. So for measles, usually this is a patient from my career. We thought it's prevented and there's no more outbreak till maybe early 2019. We started to see more cases of measles. Any thoughts why?
عشان الvaccinations دكتورة.
Yeah, exactly, because there is a group called themselves anti-vaccine group, and mainly they are against measles vaccine or MMR. Anyone know why?
Because they think it causes autism.
Yeah, because they have belief that it can associated with autism. Although it's all related to one paper by one physician. He saw an association, then he published it. Then the people started to not vaccinate their kids. Then many RCTs already conducted and assure the safety and effectiveness of measles vaccine. There is a chat. Oh, okay. Yeah, exactly. Then also the original journal, they pulled out their initial paper, but still each time there will be some group against the vaccine. So we started to see an outbreak of measles. Even the WHO, they launched a campaign aiming for zero measles by 2020. But unfortunately, the COVID hits and all the attention went to COVID. So what's the incubation period of measles? It's for the incubation period, only for measles, varicella, influenza, mumps. This is the most important incubation periods for you to remember as a medical student. So usually the incubation period of measles, it's from 8 to 12 days, ranging from 7 to 21 days. And after the incubation period, the patient started to manifest with fever. Sometimes if you are lucky in the prodromal phase, you will start to public spot, which is white white spot in the buccal mucosa against the buccal mucosa. Then the patient started to have cough, coryza conjunctivitis. They mentioned this is triple C. Then you have the characteristic maculopapular rash in a descending order. So what's the most common complications of measles? Mainly respiratory, otitis media, but the most common cause of death is pneumonia. There is also possibility of secondary bacterial infection, tracheitis. There is also a neurological complication. Some of them are acute, can happen with the measles infection. Some they will happen maybe 7 to 11 years later, like subacute sclerosing panencephalitis. This is a degenerative CNS disorder. It usually happened after 7 to 11 years after the measles infection, and usually patient will present with mainly with regression on milestone. The acute complication, it can have they can have febrile seizure, they can have encephalitis, and other complications like myocarditis. So what's the mode of transmission of measles? Anyone know?
Droplet spread and droplet spread.
Droplet and? Why you are concerning about measles? Because it is airborne. So from the viruses we will discuss today, only measles and varicella, they can travel through airborne. So they are highly infectious and they can travel for a longer distance. Clinical presentation already we mentioned, and we mentioned the complication. So what's the management of measles? There is no specific antiviral treatment. Maybe ribavirin in immune-compromised children, but still questionable. Vitamin A help to reduce mortality and morbidity from measles and through modulation in immune system. Initially, they recommend only in resource-limited country, but WHO, the latest recommendation, they mentioned it should be better to be given for all infected children anywhere. And the main mode of prevention is through vaccination. So this is just some pictures of measles rash and pneumonia, and also MRI showed high intensity in T2 for baby with encephalitis. So let's move to the second virus. For this virus, it can present as subclinical and maybe third of the patients, or present with a unilateral or bilateral neck swelling. Sometimes also some they mentioned it's the diagnostic for for this virus. You will find redness in the buccal mucosa just against the last molar. Any guess which virus is this one?
Mumps.
Mumps. So the third of the patient of mumps, they will present with a subclinical. They will not manifest any symptoms, but the commonest presentation is with neck swelling, with what we call parotitis. Is it only mumps that present with parotitis? Anyone know the answer?
Maybe rubella or
not rubella. There is a lot of viruses can cause parotitis, but parotitis we can make our differential diagnosis. We can mention infectious, non-infectious, and among infectious causes there is a viral causes. So maybe EBV can present with parotitis, CMV, influenza, parainfluenza, and in patients with the recurrent parotitis, anyone present with recurrent parotitis, we should suspect HIV. So for mumps, as we mentioned, the most common presentation is either subclinical or patient present with parotitis. The post-pubertal boys can present with orchitis. This is also a common presentation. Also, 50% of patients they can have CSF polycytosis, but only less than 1% can have meningitis. Arthritis also can present with moms. Also pancreatitis. For moms, the incubation period is ranging between 16 to 18 days, usually from 12 to 25 days, and mode of transmission through droplet. The incubation periods of moms, it's not important as measles one. So as we mentioned, the clinical presentation and complication, please remember the orchitis. Although the orchitis is a common presentation, the fertility unusual. Management only supportive and prevention through vaccination. Let's move to the third virus. For rubella, the incubation period is not important for rubella, like for your level. Mode of transmission is through droplets. A presentation mainly subclinical, but can present with mild disease with rash and lymphadenopathy. Arthritis is rare in children. One also common presentation of rubella is congenital rubella syndrome. I think you covered all the congenital infection in neonatology lecture. Complication of rubella can be complicated by encephalitis or myocarditis, as with measles. Management also supportive and prevention through vaccination. So this is just pictures of baby with congenital rubella syndrome. You can see the blue perimuffin, which can present with all the neonatal infection, and cataract, which is also not pathognomic for rubella. Some characteristic of congenital rubella infection, they can have radiolucent changes in the metaphyseals of the babies. So let's move to the next virus. So this virus can present with different presentation and different group of people. In immune competent children, the main common presentation is the rash and its characteristic slab cheek rash. If the pregnant lady got the infection early in the pregnancy, it can present, the baby can have hydrops fetalis. And in immune compromised children, they can present with a chronic pure cell aplasia. So any guess?
Parvovirus.
Exactly, a parvovirus. So parvovirus B19, the main clinical presentation of parvovirus B19 in immune competent children is with a slab cheek rash and circumoral pallor. The rash usually it's pruritic and it can wax and wane with environmental changes. This is the most important thing to remember about parvovirus B19, the clinical presentation among different hosts. So in immune competent children, as I mentioned, the main common manifestation is what they call erythema infectiosum. They name it as a fifth disease. Anyone know why they name it fifth disease? Only the parvovirus remained with the name of fifth disease. When they initially discovered the viral rash, they order the viruses that causes the rash. Then they or six, because a lot of viruses can cause rash, so they stopped. So they started with maybe the first was measles, the second I can't recall. Then they reached the fifth parvovirus. Then they stopped, and no one now believed about this order, but only parvovirus remain with the fifth disease. It can also present an immune competent adult woman. It can present with polyarthropathy. As I mentioned, an immune compromised host can present with pure cell aplasia. People with hemolytic anemia, especially the sickler, it can present with aplastic crisis among their crises. So it's important to remember parvovirus as a cause of aplastic crisis in a sickler patient. If a pregnant woman, as we mentioned, got it in the first 20 weeks, the baby can present with hydrops, fetalis, and congenital anemia, and it's a fatal condition. Also, one common presentation, mainly in adult, immune-competent adult, is what they call papular purpuric gloves and socks syndrome. It's also the same rash, and it's purpuric, mainly in hand and feet. That's what they call, why they call it gloves and socks syndrome. So this is just pictures of the characteristic rash with circumoral pallor. So we'll move to adenovirus infection. Adeno can affect any organ of the body and can present with multiple presentation, adeno and enteroviruses. For adeno, mainly presentation is subclinical. Mode of transmission of adeno is either contact or droplet, and it can present with different presentation, mainly respiratory, but it can present also respiratory and GI, but it can present with serious presentation. So for respiratory, it can present with otitis media. Most common known for adeno is the pharyngoconjunctival fever, also conjunctivitis and gastroenteritis for the GI manifestation. There is maybe more than 100 subtypes of adenos, and each subtype associated with the clinical syndrome. So 4041 can associated with gastroenteritis, 1937 associated with pharyngoconjunctival fever and conjunctivitis. For adeno, it's specific, the serious manifestation is specific for immune-compromised children. That's why they concerned about adeno in this population. Also, hemorrhagic cystitis can present in anyone, but mainly in immune-compromised children too. For the management of adeno, the focus only on immune-compromised children with some antiviral like cidofovir for them, but mainly for immune-competent is supportive management. So this is just the conjunctivitis. This is non-specific pictures. The conjunctivitis and the pneumonia. Now move to the second virus. This virus has a big group of viruses, a big family, and the main presentation of children can present with bilateral ulcerative lesion and in the same times also hand rash. Any guess?
Herpes virus?
Try with the letters here. They call it hand, foot, mouth syndrome. It's with the enterovirus. Enteroviruses is a big group of viruses. We can divide it polio and non-polio viruses. And among non-polio viruses, the commonest cause of hand, foot, mouth is Coxsackie viruses, mainly Coxsackie A 6, 10, 16, and also ecoviruses. So as we mentioned, the main presentation is subclinical, but if it's presented in babies, mainly is hand, foot, mouth syndrome. It's characterized by vesicular eruption in the hand and foot, and at the same time presented with pharyngeal inflammation and palatal lesion. Enteroviruses also can present in a neonate with a sepsis-like picture, especially if the mom had the enterovirus in the last trimester, and the baby would present with sepsis-like, and they ended up by doing all the cultures, CSF, urine, blood, and all came negative. At that time, think about enterovirus, especially if the mom's symptomatic prior to delivery. Also, enteroviruses can present with, as we mentioned, pharyngitis. It also can present with serious CNS presentation, maybe also in earlier 2000, around 2004 till 2019, there is a lot of cases presented with acute flaccid paralysis started in Japan, and we started to see these cases maybe late 2019. They present, the patient will be doing well, then sudden presentation with maybe presented with upper respiratory tract infection. Then they will have acute flaccid paralysis. The mainly it's due to enterovirus D68. No need to remember it, just remember it can present with acute flaccid paralysis. Also enteroviruses can present with gastroenteritis. Also it can present with encephalitis. So it can affect any organ like edema. So we mentioned it's Coxsackie, echo, and also polio. We will not discuss polio. It's mainly eradicated nowadays. The mode of transmission, fecal-oral and droplets. It's either through GIT or through respiratory. Clinical presentation, as we mentioned, asymptomatic gastroenteritis, or can present with hand, foot, mouth disease, or only in the mouth with herpingia, meningitis, encephalitis. We mentioned that. Also can affect the heart, myocarditis, and pericarditis. And it can present with enteroviral immunity sepsis syndrome. And for management, it's mainly supportive. IVIG showed a promising result in those patients with acute flaccid paralysis. So let's take 2 minutes break before shifting to the next family. Any question?
شكرا لك يا دكتورة.
لو سريعة بس قولوا لي، ترى أنا عادة سريعة. Okay, let's move to the next family. This is the answer for, sorry, this is someone mentioned this virus before. So this virus presented mainly with stomatitis, and then patient with eczema can present with a serious presentation. We call it eczema slash. Then can also present on those patients with Stevens-Johnson syndromes, and patients with stomatitis can they have self-inoculation of the virus if they put their hands in their mouth, and also can present with what we called slash Whitlow. So which group?
Herpes virus.
Exactly, herpes. So herpes, it's not only one. So the viruses, they can have a lot of what you call serotypes, or a lot of groups, and maybe only we discovered maybe we'd say 14 of them, and those associated with like clinical manifestations like with entero. But for herpes, all the members of the family, they have specific clinical manifestations. So anyone know how many members of herpes virus family? No one?
2.
2, okay. Any other thoughts?
7.
7, okay. Any other thought?
6.
6, okay. Any other thought?
ايش السؤال بس تكسر؟
How many members of herpes virus family known to cause the disease?
8.
8, exactly.
18.
لا, 8. So 8 members, and all they share like characteristic feature, which is all the established latency in certain neuron. So after any certain stimuli, they can have a reactivation. So what's the 8? So the first and second, we know they called only herpes simplex. The third one, is the varicella zoster. The fourth is the EBV. The fifth is CMV. And also there is herpes 6 and 7, and human herpes 8, which is only known to cause Kaposi sarcoma in HIV patients, and we will not discuss it. So for herpes 1, established latency usually in which ganglia? Anyone know?
Trigeminal ganglia.
Exactly, in the trigeminal ganglia. For herpes simplex 2, which ganglia? In the sacral ganglia. And for varicella, in trigeminal and dorsal roots. EBV is specific, so they established latency in the B cell. CMV usually in the progenitor cells in the bone marrow. So as I mentioned, they shared this specific feature. They all established latency, which they can have reactivation with a different syndrome or the same syndrome after certain stimuli. So let's start with herpes 1 and 2. Mode of transmission, usually contact. For herpes simplex virus 1 is usually associated with lip and skin lesions, as I showed you the pictures. For 2, it's more common with genital lesion, but both viruses, 1 and 2, it can present with both types of disease. So this is just pictures of a baby, as I showed you before, with eczema, and it can present with a serious manifestation. It's called eczema herpeticum, and patient with eczema, and sometimes also superimposed with bacterial infection, mainly Staph aureus, which could complicate the picture. And also it can present with Stephen Johnson in this population. Main presentation is stomatitis. This is just not to differentiate between the transient erythema toxicum in neonate with a neonatal group. Herpes simplex can present with a different manifestation. It can present most commonly with only localized skin, eye, mouth disease, or it can present with only isolated encephalitis, or it can present with disseminated disease in the natal group. In other babies, it can present with subclinical, and as I mentioned, with vesicular gingivitis or herpetic Whitlow, or it can also present with encephalitis. So this is just the pictures, and you can see the patient, a baby with eczema, can present with a serious presentation. And this is the herpetic Whitlow of the patient with lesions in the mouth. This is a neonatal with a disseminated lesion, and this is the neonate with only skin, eye, mouth disease. So as I mentioned, clinical presentation can present asymptomatic with gingivitis. The main complication or reasons of admission with gingivitis in kids is dehydration. Usual skin manifestation, as I mentioned, other skin manifestation, eczema herpeticum with secondary bacterial infection, herpetic Whitlow. Also, herpes can present with conjunctivitis and corneal ulceration. CNS, as I mentioned, aseptic meningitis is not as common as encephalitis for herpes. And neonatal disease, as I mentioned, skin, eye, mouth, or CNS, or disseminated. Also, herpes can present with a disseminated and serious manifestation in immune-compromised children. So for management of herpes, usually supportive. Acyclovir, it's in certain clinical condition, mainly with immune-compromised children. Some with gingivitis, there is no supportive study for acyclovir in gingivitis, but still some doctors, they will prescribe oral acyclovir. others, I will leave it like this. In certain clinical conditions, it's advanced into your level. So let's move to the second one. The second virus can present with, let's say, after the incubation period, which is important to remember. I can present with skin rash, can present different skin types, skin rash types like babule, vesicles, pustules, also crusted lesions, all in the same times. And it's itchy, immune compromised. It can present with a hemorrhagic, disseminated hemorrhagic picture. So, any guess?
Rubella.
Already we mentioned rubella.
varicella.
Varicella, it's within the herpes family. So for varicella zoster, it's human herpes 3. As I mentioned, it's important to remember the incubation period of varicella. It's ranging between 14 to 16 days. After that, the patient started to have high fever and the rash will start. Usually the rash started in the face, trying and distributed, and it's a very itchy rash. And it can present with different rash types on the same times, papules, physical pustules, and crusts, and you can have 50 to 500 lesions in the same time. The patients are mainly worrisome complication of varicella in immune-competent children is the superimposed bacterial infection, mainly with group A strep. It can present with necrotizing, I have pictures, with necrotizing fasciitis, which is a surgical emergency. So this is the worrisome complication of group A strep. Also, it can present with necrotizing fasciitis or with strep shock syndrome. It can present with is a streptococcal. Also, complications of varicella can present with cerebellitis or encephalitis. In immune-compromised children, it can present, as I showed you, with a hemorrhagic lesion. Also, pneumonia, disseminated disease in immune-compromised children. In babies, they can have congenital varicella, and the main characteristic of varicella in babies, it can present with scarring skin lesions. This is just the pictures of the rash, and this is the baby with secondary bacterial infection. This is the necrotizing fasciitis I'll show you before. So the incubation period, it's 14 to 16, and mode of transmission, just remember from this lecture, measles and varicella through airborne. Varicella airborne and contact, measles droplets and airborne. Clinical presentation, as we mentioned before, mainly management for immune competent is supportive to give calamine lotion, cutting nails to prevent secondary bacterial infection. Oral acyclovir is a questionable in the acute presentation in immune competent children. Because usually after 3 days of the rash appearance, the virus will stop replicating. So there is no point to give oral acyclovir. Despite that, still some physician and clinician, they will give oral acyclovir. IV acyclovir, an immune-compromised patient. Also an immune-compromised patient, after they're exposed to any patient with varicella, we give them a varicella immunoglobulin as post-exposure prophylaxis. And the main way to prevent varicella is through vaccination. So this is the same virus, but after reactivation, it can present as
shingles.
Shingles, herpes zoster. It's not common in children, it's mainly on adults. So we must not spend a lot of time. As we mentioned, it's the reactivation of latent varicella. And because of the latency for varicella in trigeminal and dorsal roots, it's usually presented with localized through one dermatome, mainly in trigeminal. And if the varicella in the ear, it can present with, anyone know the syndrome? It's called Ramsay-Hunt syndrome. The patient will present with facial palsy and with the vesicular rash of varicella in the ear. This is also from the herpes virus family. So let's say this is a 6 years old boy presented with pharyngitis, and it's exudative pharyngitis. The primary physician thought it's a bacteria, so he prescribed amoxicillin. After amoxicillin, he started to have a rash. With the investigation, found it to have atypical lymphocyte. Any guess which herpes is this one?
ABV.
EBV, exactly. So EBV, infectious mononucleosis, glandular fever. The main presentation, it's asymptomatic, but the commonest presentation, if symptoms happened, it's infectious mononucleosis, which is fever, lymphadenopathy, hepatosplenomegaly, and pharyngitis, mainly exudative with EBV. And in the peripheral smear, they will have atypical lymphocytosis. Rash, as I mentioned, if the patient's given ampicillin, amoxicillin, as presumed they have bacterial infection because of the exudative pharyngitis, they will develop rash. Patients, if they have a CNS manifestation, can present with different manifestation from meningitis, transfer myelitis, cranial nerve palsy. For hematology, it's like specific, not specific, I will mention, but characteristic of EBV, huge splenomegaly, which born the patient to splenic rupture, thrombocytopenia, hemolytic anemia. EBV also can associated with some malignancies like lymphoproliferative disease, nasopharyngeal carcinoma, and Burkitt lymphoma. For EBV, it's good to know how to diagnose EBV at your level. So as I mentioned, in the peripheral blood smear, they will have atypical lymphocytosis. And this is not characteristic for EBV. It can present with different viruses, EBV, CFV, and other viruses. They can have atypical lymphocytosis. If children more than 4 years old, they can have a positive monospot test, which is the presence of heterophil antibody. And the main way to diagnose in younger people is through the antibodies, which is called viral capsid antigen, IgG, IgM, early antigen, and EBV nuclear antigen antibodies. And I will show you a table how to diagnose acute or past or recent infection. So this is the atypical lymphocyte and peripheral blood smear. And how to diagnose EBV. So for varicella capsid IgG, it will present either acute, recent, or past infection. It's not characteristic for any type of infection. Presence of varicella capsid IgM indicates the acuteness of disease. It presents with acute, but sometimes it will also present with recent. Early antigen can present with any types of acute or recent or past infection. EBV nuclear antigen, the presence of EBV nuclear antigen, it means it's a past infection, it's not acute. So if the patient presented with, let's say, mononucleosis-like picture, and he had EBNA positive, so we mentioned it's maybe secondary to other viruses, not EBV, because EBNA is positive. And just this is different manifestation. This is rash after patients giving amoxicillin, and some they will present with conjunctivitis. Management only supportive. Corticosteroid or steroid in general given in certain clinical condition and a serious clinical condition. So when we afraid the patient will have upper airway obstruction secondary to significant lymphadenopathy, or the patient have massive splenomegaly, or patients have hemolytic anemia or myocarditis, corticosteroid should be given. Also, we should avoid ampicillin, amoxicillin. Avoid exercise in patients with severe splenomegaly to avoid splenic rupture. So next virus in herpes family. This virus can present with a main presentation, let's say subclinical, but if presented, can present it with a mononucleosis-like syndrome with significant splenomegaly too, and neonates present with a neonatal infection. They can have the peri. It's not specific also for this virus, but what's specific for this virus is the histological features of intracellular inclusion, which present with a typical owl eye sign. So which virus is this one?
Congenital CMV infection.
So this is CMV, yes. The presentation, the main presentation of CMV, as I mentioned, subclinical, but if presented, it can present with mononucleosis-like syndrome. So the patient will present with maybe splenomegaly fever and lymphadenopathy, which is less prominent as with EBV. The patient will have atypical lymphocytosis, as we mentioned, but they will have a negative heterophil antibody. Patients can present in a neonatal period with congenital CMV, which is covered on a neonatology lecture. CMV can present, the problem with CMV, it's transmitted through any secretion, through body secretion, like through saliva, genital secretion, breast milk. So the mom, if they are infected with CMV and they have preterm babies, so we advise those moms not to breastfeed their infant because the risk of transmission of CMV through breast milk. But if the baby is full term, there is no risk to acquire CMV. So we advise with breast milk feeding. We mentioned the clinical presentation. CMV had specific presentation in immune-compromised children, present with retinitis, pneumonitis, and bone marrow suppression. But the most common presentation, especially in HIV patients, is retinitis. That's why they will have a regular retina checkup. So this is just a picture of congenital CMV. And this is retinitis. This is not only for, sorry, this is cataract. I thought I put a picture of retinitis in HIV patients. For management, antiviral only in immune-compromised kids, or sometimes we can give in congenital CMV. The antiviral, it's ganciclovir. The oral form is filganciclovir or with foscarnet in case of resistant. It's advanced to level. So herpes simplex 6 and 7, they called exanthema subita or rosula infanta. They have characteristic clinical presentation. Just remember this clinical presentation about it. They will present with a high fever, then 1 to 2 days after the fever subsides, they presented with a rash. It's a common in kids to have this presentation. And rarely they can cause meningitis, hepatitis, and immune-compromised children. The latest virus is influenza, and also influenza, it's important to remember the incubation period of influenza, which is usually 1 to 4 days. And the mode transmission, as all of us know, is droplets. Clinical presentation of influenza, it's known for anyone. It can present mainly with respiratory, but a serious complication, it can present with encephalitis, which is a serious, and can present with what we call necrotizing encephalitis. It's a very serious presentation of influenza. or a secondary bacterial infection can present also with myocarditis. So the management of influenza usually supportive, but if the patient presented required hospitalization or presented in the first 3 days, we can give Tamiflu or the name of Tamiflu is oseltamivir. And as soon as possible, as I mentioned, because it can work well in the first 48 hours. But if the patient required hospitalization, we will give anyway. So main preventive is through vaccination, and now since October the campaign of influenza vaccine usually started, and usually the vaccine influenza they have 3 known subtypes A, B, and C, and usually the vaccine is targeting which subtypes, you know? A and B, and prior to COVID have slight mutation mainly to the A, and how can they recombine a new vaccine or which to include in this new vaccine. Also, one way to prevent is post-exposure prophylaxis in certain population. We can give them oseltamivir. So that's it for influenza. I didn't include COVID because it's not in your curriculum. And thankfully, it's not common in children. But if you have any question, feel free to reach me through my email. So that's it for the first lecture. Any question?
الله يعطيك العافية، ما قصرت يا دكتور.
في أحد عنده أي سؤال؟ أي استفسار؟
طيب معلش دكتورة، بس بالنسبة للفيروسات أحتاج أعرف كل فيروس و
تسهل ليكتشر
مش
second lecture. أي تفضل. ما أسمع.
إيه المعذرة، أسأل يعني وش المطلوب بالضبط؟ هل الروت أف ترانسميشن والمانجمنت فقط ولا
clinical presentation, mode of transmission, ومانجمنت، incubation period. قلت لكم بس measles varicella، لأني عارفة لو قلت لكم احفظوها كلها ما حتحفظونها، صعبة تتذكرونها. let's focus على الimportant اللي هو measles، الفاريسيلا والinfluenza. This is the important incubation period at your level to remember.
تمام، شكرا.
ناخذ 10 minute break.
أوكي
تمام.
تمام.
أوكي نرجع 9:33.